actually, okay, I think I should tell. So, if we talk about the cell wall of the bacteria, so always remember that it may be either, basically if you talk about the gram staining, so there can be a gram positive bacteria and there can be a gram negative bacteria. So if we talk about a gram positive bacteria, why is it gram positive? Because it takes up the gram stain. Okay, it can hold the gram stain. But if it is gram negative bacteria, that means it cannot hold the gram stain. What is gram stain? Gram stain is nothing special. It is basically a crystal violet. So normally what happens is that if you have on the outer side, I'll just give you a very brief idea since you are not capable of saying. So I'll just give you because this is more of a microbiology. So since I'm not teaching microbiology, so I'll just give you a very brief account of what it is. So is this whiteboard visible?
Yes, sir.
Acha. Now?
Yeah.
Acha. So actually, if you have got one bacteria like this, now what happens is in this bacteria there are present these kinds of, there is a N-acetyl glucosamine. Okay, it's basically a type of carbohydrate, glucosamine. It's derived carbohydrate. So here there will be N-acetyl glucosamine, N-acetyl glucosamine, and then here there will also be another thing, that is the N-acetyl muramic acid. Okay, there is N-acetyl. So this is basically N-acetyl muramic acid. So there is N-acetyl glucosamine and there is N-acetyl muramic acid, and in between them what happens is there is transpeptidation. There will be like this transpeptidation going on, like this. They are linked in this way. So there is one kind of bacteria like this. Then there is another kind of bacteria. Now what does that bacteria look like? Now that bacteria, there is a very naughty bacteria. Why it is naughty bacteria? Because actually not naughty, it's very clever bacteria. So this bacteria has got actually a lipid layer. It actually has got a lipid layer all over here, like this. What is this? This is basically lipopolysaccharide, not purely lipid, like lipid with sugar, lipopolysaccharide. And then there is also another lipopolysaccharide present. Now if in between them, if we look at it, do you see that in between the two lipopolysaccharide layers there is present a tiny space?
Yes, sir.
So that is called as a periplasmic space. So there is a outer layer and then there is a inner layer. Now the basic funda is this, ki if you are using say a crystal violet, now do you think lipid can actually on oily substance you can actually write something?
No, sir, parvo na.
No. The simple funda, if you are adding crystal violet, so what happens is crystal violet remains trapped in this network. It cannot go out. Once it gets in, it is trapped in this network area. But if you are adding crystal violet on this thing, is this going inside? Is it getting trapped anywhere, the crystal violet?
No, sir.
No. So if you are washing the right hand side wala bacteria, then the crystal violet will get easily washed away. But if you look at the left hand side bacteria, howsoever you are going to wash it, it is not going to go away. It is trapped over there. So if the stain washes away from the membrane, then can you see a cell? If you cannot stain, then can you actually see a cell?
Na, sir.
Na. So simple thing. First you take an unknown bacteria, you put crystal violet in it, and then you look at it under you wash it, of course, you wash it, you look at it under microscope. There can be two situations. One is you see bacteria, point two is you don't see anything. So if you see bacteria, tell what does it indicate? It has taken up gram stain. That means it will be gram
Positive.
positive. Yes. But if you are not seeing anything, that means you have no clue whether really the bacteria is present over there or not. So to confirm, what you are going to do is we will use a counter staining. Now that counter staining actually can bind with the surface, like saffron in red or those things, they are added. So that is called as a counter stain. So now when they will bind to it, so then under microscope we would be able to see. But as far as the gram staining is concerned, you understand that is not taking up the gram stain. So it is gram what? Negative. Yes, of course there are some other types as well. Say if you talk about mycobacterium. Do you know what is the specialty about mycobacterium?
স্যার ওদের সেল ওয়ালটা ঠিক মানে হয় না বোধহয় মানে মাইক্রোব্যাকটেরিয়াম গুলো তো ছোট ছোট ব্যাকটেরিয়াম সব না ওগুলো তো মাইক্রোপ্লাজমা ছিল স্যার
Nobody knows mycobacterium. You cannot kill a mycobacterium or you cannot stain a mycobacterium with gram staining. So for that you need a separate Zeal Nilsal staining. So Zn staining you have to do, only then you can get it. You cannot get it by a regular gram staining. Achha. So this is the idea of the cell wall. So my point is that whatever antibiotics that we are going to use, so everybody clear about the cell wall in brief?
Yes, sir.
Okay. So if we start talking about this cell wall inhibitors, so here primarily like the most common drugs, penicillin, most common cephalosporin, okay, they are inhibitors. Who is inhibiting whom? All those things. We are going to see it in this lecture. Okay, so we are going to, first topic is going to be the very common topic, that is the cell wall inhibitors. So if we talk about the cell wall inhibitors, the first and foremost thing that we will talk about is the penicillin. Now if you can see the picture over here, because here you should have a little bit of idea about the structure, at least in a schematic way. You don't need to know about how many methyl groups are present or where is CH3COOH present, but at least you should know how it looks like. Don't you think that it is more of looking like it is more of looking like a castle, like
Yes.
like this? So this is how you try to recall the structures. Not like you don't need to know what is present in these places. You just get to know how the structure overall looks like. I think that will be enough for you. So penicillin is a drug. Like where do we use penicillin? How many of you have heard of amoxicillin used in dentistry?
Regularly
Exactly, that is penicillin. So that is why you can see it's most widely effective and it is least toxic. So that is why it is so popular. I use it even in case of pregnancy patients. If a pregnancy patient develops a oral infection and I need to heal it, so once again I am going to use penicillin. Now problem with pure penicillin, like because see, penicillin was actually obtained from that I think some Alexander Fleming, who obtained it from a fungus, Penicillium notatum. You remember?
Yes, sir.
So it is a way old drug. So definitely it will be having a high amount of resistance also. And that is why the original penicillin is no more in use. That is why we have to use different forms of penicillin. Like amoxicillin is not the original, like fungus obtained penicillin. It's a form of it. So the reason is this, that here do you see that there is a R group present? Like there is a RCH3COOH. Can you notice in the lower side?
হ্যাঁ স্যার
Yes. Now this R substituent is going to connect to the 6 amino penicillinic acid residue. Okay, so that actual picture, that castle kind of a picture that you see, that is basically 6 amino penicillinic acid residue. Okay. Now the nature of the side chain is going to affect the spectrum. We will see gradually that only. That the nature of the side chain, how the side, that is why I asked you to, just at least go through the structure. That who is the side chain? Understand until you observe or recognize the side chain, you have to just mug it up. So nature of this side chain affects the antimicrobial spectrum, stability to stomach, cross hypersensitivity, and susceptibility to bacterial enzymes like beta lactamase. So what is this beta lactamase? This is the enzyme which is going to cut these bonds. So these bonds will be broken and your 6 amino penicillinic acid is gone forever. Okay, so that they have like bacterial enzymes. So we will discuss about them later on. So clear everyone for the time being?
হ্যাঁ স্যার
All right. Now let's see what is the mechanism of action. So you remember I told you that first there will be nag, then nam, then nag, then nam, then nag, nam. So there is a continuous, nag, nam situation going on. Now what happens is, like I said, that there is a condition where there is going to be that transpeptidation, that is cross-linking. Like I gave you a raw picture, but here you see, if you look at the diagram, it is more elaborately explained, very well explained over here. So there will be transpeptidation or cross-linkage. Okay, and the exposure of osmotically, like it will result in the exposure of the osmotically less stable membrane. Okay, because less stable membrane is the inner cell membrane, है ना? So that is osmotically not very stable. If you take a bacteria and the bacteria does not contain any cell wall, you getting? So if a bacteria does not have cell wall, so if you put that,
স্যার এফেক্ট করবে না
no, if you take a bacteria without any cell wall, and if you take the bacteria and dip it in a strong saline solution, what do you think, it will be able to survive or not?
না স্যার পারবে না, ওটা তো হয়ে যাবে, কি বলে হাইপারটনিক সলিউশনে আছে তো স্ট্রিঙ্ক করে গিয়ে মরে যাবে।
Right. So that is what is written, that if you take the bacteria and dip it in a saline water, there will be osmotic burst.
Yes, sir.
Okay, and so that is why, to protect that thing, so we have got, or the bacteria, not we, the bacteria develops those nagnam thing. So these drugs, if they are damaging the cell wall, you tell me, these drugs are killing the bacteria, or these drugs are restricting the colony count of the bacteria? What do you think are they doing? I am asking ki, if there are two ways we can destroy these bacteria. Way number one is you restrict the colony count, and way number two is you kill them. So which one do you think are they doing?
Sir, colony count টাই তো colony count restrict করছে না, kill করছে তো।
So remember, if there is any antibiotic which is restricting the colony count, so that means it is reducing its effectiveness but not killing, right?
Yes, sir.
That is bacteriostatic.
Okay, sir.
So if we talk about bacteriostatic, so bacteriostatic means it has stopped, it has frozen the bacteria. It is not going to allow the bacteria to grow any further. So that is bacteriostatic. But if it starts killing the bacteria, then that is called as bactericidal. Okay.
Yes, sir.
Right. Now, uh, whether a penicillin antibiotic will be successful or not, that is related to the size of the antibiotic. So, the antibiotic will be able to pass through different compartments of your body or not. What is the charge that it is carrying, and whether it is hydrophobic or not, or how much hydrophobic it is. Okay, and also remember that penicillins are only effective against rapidly growing organisms who synthesize a peptidoglycan cell wall. Now, suppose that there is a bacteria who has already got a peptidoglycan cell wall, already produced cell wall. Do you think over there your penicillin will help?
No, sir.
So that is why the that is the point. So, do you think we can use penicillin to work against say fungus or virus or mycobacteria, because they don't have cell wall? Nah. So this is the point. Okay. So unless and until you actually are creating cell wall, we cannot kill the bacteria with using of penicillin. Now, where will this penicillin bind? So actually, if you look at the picture, you will notice that there is this penicillin, that picture, the cartoon that you can see penicillin, that looking like a castle, upper side, ekdam upper side. So that's the penicillin. And if you look at that green S-shaped structure, hook-like structure, so what is that? That is called as a penicillin binding protein. What is the penicillin binding protein doing? It is actually helping in the transpeptidation. See in the picture, it is so nicely given how it is doing transpeptidation. You can see na?
Yes, sir.
So bas simple, penicillin is going to engage the PBP, that is the penicillin binding protein, the S-shaped structure. So if the S-shaped structure is already taken up by the penicillin, then do you think there will be transpeptidation taking place?
না স্যার তাহলে তো আর হবে না যদি বাইন্ড করে যায়
Exactly. But
ইনহিবিট করে
it becomes osmotically unstable, bacteria dies. Now, okay, now like if we talk about alteration of some of these target molecules, they provide the organism with resistance to penicillin. So there is a thing called as methicillin resistant Staph aureus. Staph is Staphylococcus, methicillin resistant Staphylococcus aureus, MRSA. So that resistance developed because of this alteration. Understood?
Yes, sir.
হ্যাঁ স্যার
Right. Now, let us talk about this inhibition phase. So, some penicillin binding proteins, they catalyze formation of the cross linkages between peptidoglycan chain. So, penicillins inhibit this thing, and as a result of this blockade of cell wall synthesis, the PARC nucleotide or PARC peptide, that is like specifically it is written as UDP acetyl muramyl L-alanine, D-glycine, L-lysine, D-alanine accumulates. Basically what is written over here, do you see? That's what they were writing. The D-alanine goes away na? So if you go with the color coding, you will see that first there is NAM, N-acetyl muramic acid. So over there what is present? L-alanine, then yellow D-glutamate, then purple L-lysine. Okay, then bottom of that there will be D-alanine. Then on the sides there is blue. The blue is what? Blue is basically glycine. Can you correlate?
হ্যাঁ স্যার
So this is what is discussed over here. All right. So UDP acetyl muramyl L-alanine, then D-glycine, L-lysine, D-alanine. So if you recall, see that thing, the lamba wala chain, D-alanine, orange at the bottom side. So that is going to get accumulated. That will not work. That will not help in formation of the cell wall synthesis. Okay. All right. So that's how it works. Okay. Now moving on to the antibacterial spectrum. So there is a huge spectrum of penicillin. So the whether it will be able to cross the bacterial peptidoglycan cell wall to reach the PPPs in the periplasmic space or not. So that is going to be the factor. Plus that charge hydrophobicity, all those things I have already told you. Now, since you already know what is the difference between gram positive and gram negative, so let me tell you something, that even gram negative, they have certain proteins inserted in the lipopolysaccharide. Okay, so these proteins are called as porine. Okay, so they are known as porine. Have you heard of this thing porine before?
Yes,
No.
sir.
হ্যাঁ স্যার
Acha.
ওই তো
হ্যাঁ।
চ্যানেলসগুলোকে
Yes, Pseudomonas aeruginosa has restrictive porins. So if it is restrictive porins, then antibiotics will not be able to work in restrictive porins. Okay, so like basically here we are talking about how we can attack. So as far as your gram positive is concerned, prevent it from making the cell wall, and as far as gram negative is concerned, you have to target the porins, so that through that porins the substances can get inside and create the cell burst. Okay, and accordingly the penicillins can be natural penicillin. So initially there was penicillin G and penicillin V, but problem is that they were not at all working against staphylococcus. Okay, so since they were not working against staphylococcus, so then came up, I'll tell you how, what, when. So just trust me, the chronology. So to prevent them, there came up some special drugs. So some special kind of modified form of penicillin. So like methicillin, oxacillin. See penicillin, so cillin word should be there always. So methicillin, oxacillin, nafcillin, like that. Cloxacillin, dicloxacillin, like that. Then there is something called as extended spectrum. Again, there is a reason for this. So over there comes up ampicillin, then amoxicillin. This is what we use in the dentistry. That's so you understand that in dentistry we use basically an extended spectrum. Carbanicillin is also there. Why and all I'll tell you in a while. Then we have got beta lactamase inhibitors, which also I'll discuss. What do they do? What is this? But okay, why telling? I told you that there are some of these bacteria. They possess their intrinsic enzyme called as beta lactam enzyme. You remember we discussed it a couple of slides back.
হ্যাঁ স্যার
They are going to actually cut that chain, the 6-amino penicillinic acid. So it actually cuts it. So if it cuts it, it is actually destroying the penicillin itself. So we have to stop that beta lactamase also. Because if you don't stop the beta lactamase, then using penicillin is a waste. Correct, na?
হ্যাঁ স্যার
Right. So you see, if we talk about natural penicillin, that is the penicillin G and penicillin V. So like primarily, if you talk about any penicillin, even like that anti-staph, they are all obtained from that penicillium. So which penicillium? Penicillium chrysogenum. Okay. So anything which is obtained from penicillium chrysogenum, what do you think? It is natural or it is artificial?
স্যার ন্যাচারালি হবে কারণ পেনিসিলিয়াম লাইসোজেনাম ইজ মানে
Very good.
variety of
But suppose I talk about ampicillin. So in ampicillin, is ampicillin obtained from Penicillium chrysogenum? No. So over here, remember that though it is not obtained from Penicillium chrysogenum, but if you talk about the R group present in ampicillin, so R group, like there will be different R groups which are attached chemically to 6-amino penicillinic acid, obtained from fermentation of broth of the mold. Are you getting the point? So mainly the R group is obtained from broth of mold, fermentation products. So can we say it is purely synthetic, or we should say that it is both?
স্যার বোথ বলা যায়
Exactly. That is why it is called as semi-synthetic. It is not synthetic, it is not natural. So it is semi-synthetic. So if you talk about penicillin G, so another name for penicillin G is benzyl penicillin. So it is a prototype drug. So if you see that there is any gram positive, gram negative cocci or gram positive bacilli if you talk about spirochetes, in all these cases penicillin G can be used. Okay, and like I was talking about that beta lactamase, see it is also written over here. Now talking about penicillin V, penicillin V is not well absorbed. So if penicillin, any drug is not well absorbed, do you think we can have good use of it?
No, sir.
No. So that's the point, that penicillin V is more stable than penicillin G, but it is having a very poor absorption. Okay. But once again, if you are using penicillin V, so penicillin V is more acid stable. So you can use it in the like oral drugs, so that it will go to the stomach and nothing will happen to it. Like maybe a drug you are using IV or IM, but here since penicillin V, you can use it orally also. So can you understand with the, can you correlate it with the diagram? All the points we have already discussed. All right. So moving on. Now we have got something called as anti-staph penicillin, and here you need to know the names also, that methicillin, nafcillin, oxacillin, and dicloxacillin, like I was telling earlier, are penicillinase resistant penicillin. What is penicillinase? That's the beta lactamase. So beta lactamase will prevent beta lactam, and if you prevent beta lactam, that means like you are making it ineffective, making the penicillin ineffective. So their use is restricted to treatment of infections caused by penicillinase producing staph, including that MSSA. What is MSSA? Methicillin sensitive staph aureus. ठीक है?
Yes, sir.
All right. Now, if you talk about the anti-staph penicillin, now that medication that I have given you on the right side is very commonly used drug. Okay, Ampilox is a very commonly used drug. So what does it contain? It contains ampicillin and dicloxacillin. Okay. So if we talk about the anti-staph penicillin, so here the same thing, methicillin, nafcillin, oxacillin, dicloxacillin, they will come up. Now their use is restricted to treatment of infections caused by penicillinase producing staphylococci, including MSSA. Okay, because of the toxicity, what used to happen if you were taking this drug, you were suffering from interstitial nephritis. So because of the fear of interstitial nephritis, methicillin is not clinically used. And as far as methicillin is concerned, so there is already a thing called as MRSA, methicillin resistant staph aureus. Okay, and MRSA is something which you actually catch from contaminated place like hospital. It is called as nosocomial. Nosocomial means hospital acquired, because in hospital there are different type of people living, na. So in hospital is also a breeding ground of germs. So if you catch any kind of disease from the hospital, we call it as nosocomial infection.
So it is community acquired pneumonia.
You can say so. Alright. Now if we talk about such kind of organisms, then how can we treat them? Because these drugs are not enough to treat them. So what do? We use vancomycin. Later on I'll teach you what is vancomycin. So we will use vancomycin. Okay. Now if we talk about the next thing, so that is the extended spectrum penicillin. Like example was written already, ampicillin. So what is the point? Ampicillin and amoxicillin, they have a spectrum which is similar to penicillin G. So penicillin G also has a spectrum which is not very effective, but it had it. Now that is similar to the natural effect. Amoxicillin, ampicillin, their use is more syncing with the natural effect, because they are working like they have the antibacterial spectrum similar to the G only, and also they are effective against the gram-negative bacillus. So don't you think that it is working what a natural penicillin can do and beyond? है कि नहीं?
Yes, sir.
Yeah. Now what happens is, that are you acquainted with the term gentamicin?
হ্যাঁ স্যার
So what is gentamicin?
টার্মটা জানি জেন্টামাইসিনটা জানি না মানে কি পারপাসে ইউজ হয় সেটা জানি না।
Okay, gentamicin is also a type of antibacterial only. So later on, I'll teach you in this antibiotics only. I'll teach you someday that there is a category called as aminoglycoside. There is a group of chemical called as aminoglycoside. So this is this belongs to that. Gentamicin is a type of aminoglycoside. So remember that ampicillin is the drug of choice for any gram-positive bacillus, Listeria monocytogenes, and enterococcal species. These extended spectrum agents are also used widely in the treatment of respiratory infections, and amoxicillin is employed prophylactically by dentists for patients with abnormal heart valves who are to undergo extensive oral surgery. Because if you don't have a good heart valve, then there is a chance which is called as severe acute bacterial endocarditis. It's called as a SABE. Okay, SABE, severe acute bacterial endocarditis. So to prevent SABE, before surgery, a patient should be injected with or given these amoxicillin. Okay, and resistance so definitely will be there. Now if you like, there was beta lactamase present. Okay, now nowadays what is available, even I specifically prescribe those things only to the patient, that if you are using a amoxicillin with a beta lactamase inhibitor, it can be possible, na? Like inside the amoxicillin only you hide some beta lactamase inhibitor, so then that will be good, right?
Yes.
Yes.
হ্যাঁ স্যার
Later on you will see clavulanic acid we use for a long time, and also like there will be other examples like sulbactam, tazobactam. Okay, so these are the ones who actually are beta lactamase inhibitor. They protect this amoxicillin or ampicillin, okay, from hydrolysis. So understood everyone?
হ্যাঁ স্যার
Yes.
All right. Now, if we talk about say the anti-pseudomonal penicillin, now these are all even dangerous. So there is some names like carbanicillin and ticarcillin. So also, there is a piperacillin or piperacillin. They are called as anti-pseudomonal penicillin because of their activity against this P. aeruginosa. And piperacillin is most potent of these antibiotics. So remember the name. They are effective against many gram-negative bacilli except Klebsiella. Remember, this is good for MCQ. Okay, exception wala question. Except Klebsiella, because of its constitutive penicillinase. And formulation of ticarcillin or piperacillin with clavulanic acid or tazobactam extends antimicrobial spectrum of these antibiotics to include penicillinase producing enzymes or organisms. You remember I told you tazobactam is also there, sunbactam and tazobactam. So this is the effect of tazobactam. Clear?
হ্যাঁ স্যার
Okay. Now, like I was telling you, gentamicin. Gentamicin is categorized under this aminoglycoside. So you will see that. What do you think? Their action should be synergistic or antagonistic? What do you feel?
স্যার অ্যান্টাগনিস্টিক হওয়া উচিত তো
See, both are antibacterial. Aminoglycoside also wants to kill bacteria, and amoxicillin also wants to kill bacteria.
স্যার তাহলে একটা কম্পিটিটিভনেস হওয়ার কথা না
Why competitiveness? Bacteria, it is working on bacteria, not receptor. Suppose there are 1 lakh bacteria. So you are giving only amoxicillin. So amoxicillin binds with, let's suppose, 50,000 bacteria. Now you add, say, aminoglycoside to it. So don't you think that will again further bind to rest 50,000 bacteria?
হ্যাঁ স্যার বুঝেছি হ্যাঁ
So use of these two drugs are basically synergistic in nature. Remember this. Okay?
ওকে স্যার
Yes. Okay. So that is also there. Now, if we talk about that penicillin and aminoglycoside, they are synergistic because cell wall synthesis inhibitors alter the permeability of bacterial cells. These drugs can facilitate entry of other antibiotics because see the target is this. All of you have seen football. You have seen the game football. Everybody.
Yes,
Yes,
sir.
sir.
Yes. So, have you ever seen such kind of game that suppose there is a midfielder who is having the football, so the midfielder is going towards the goal, moving. Just before in front of the D, that D which is drawn in front of the goal, just in front of that the goalkeeper the midfielder stops the ball and runs away. And behind the midfielder there was a striker who comes up and shoots and it is a goal. Have you seen this kind of tactics?
Yes, sir.
Okay, I don't think everybody has seen it.
না
In-
স্যার অত কিছু
Acha, imagine, suppose there is a army who is trying to go for a rescue operation, say Taj Hotel. So have you seen that they are standing, suppose 4 or 5 people are standing outside the room and they have to barge inside the room. So there will be 2 people who will be standing with the guns, like anything happens they are ready to shoot. And then there will be 2 people who will be actually opening the door. So the people who open the door, they don't go inside first. 2 people will open the door and behind them there will be 2 bandukdhari present and they will enter in. Have you noticed this?
হ্যাঁ স্যার বুঝেছি এবার হুম
So similar is the synergistic action of penicillin and aminoglycoside. Penicillin will stop cell wall synthesis. Now when it will stop cell wall synthesis, aminoglycoside will smoothly slide inside and alter the porine protein. Bas, cell damage, khatam, kahani. Understand?
হ্যাঁ স্যার এবার বুঝেছি
Yes. So that is the effect. How are they synergistic? So there is an enhanced antimicrobial activity. Remember this. So like combination of penicillin and aminoglycoside are used clinically. But problem is that if you are using injection, then you should not use it you cannot mix the injection. You can inject them separately. Like first you inject amoxicillin, then you inject the aminoglycoside. But you don't mix it. Okay, because on prolonged contact, aminoglycoside is positively charged and penicillin is negative charged. So no, positive negative will join and become neutral. Okay, so that is something that you should avoid. Understood the point?
হ্যাঁ স্যার
All right. So next, that problem that we face, that is resistance. So as far as the resistance is concerned, it is a case of natural resistance and like occur in organisms that either lack a peptidoglycan cell wall. Mycoplasma doesn't have it. You guys only told it. And there will be some other organisms who have cell walls which are impermeable to the drug. Then along with that, resistance can come up through plasmid. Plasmid contains antibiotic resistance genes. So through that also it can happen. Okay. So both ways it is possible, resistance. There is nothing more to discuss in resistance. I hope you understood.
হ্যাঁ স্যার
Okay. Now comes up this beta lactamase activity. See, this is the thing that I was telling you, that they hydrolyze the amide bond of the beta lactam ring. So that is why its name is beta lactamase activity. And if you have, this is the most commonest type of resistance that a bacteria can give. The bacteria carries the cutter of the antibiotic that will be provided to the against it. So some beta lactam antibiotics are poor substrates for beta lactamase, and thereby they are going to resist hydrolysis. So only then these antibiotics will be effective. Okay, if your beta lactamases cannot break somehow cannot break the that beta lactam ring. Okay, now gram positive organisms secrete beta lactamase extracellularly, whereas gram negative bacteria confine the enzyme in the periplasmic space within inner and outer membrane. So remember this thing, okay, because this is very essential. Ki which drug will work at what level? Gram negative, beta lactamase is in periplasmic space. Gram positive, beta lactamase is outside the cell. Next is there will be decreased permeability to the drug, because there is, through the outer cell wall, the bacteria will prevent the drug from reaching the target PBVs. So, and also there is a efflux pump present which will keep pumping out the drug. So intracellular drug concentration will keep reducing. Understand?
Yes, sir.
Okay. Next thing that you should remember, that is there is a concept of altered PEPs. So if you are modifying the penicillin binding proteins, then there will be a lower affinity for beta lactam antibiotics. So beta lactam won't recognize those things if you can modify the penicillin binding proteins. And so this requires clinically unattainable concentration of the drug, and hence that will affect the inhibition of bacterial growth. Okay, so these are some kinds of resistances present. And if you talk about the kinetics, so I hope you understand this, ki amoxicillin can be used with combination with clavulanic acid, which we very commonly give, amoxclav, we say it this way. Then ampicillin with sulbactam combination is there. Then other than that, whatever we discussed, say tazobactam can be used with piperacillin or piperacillin. Okay, so all these combinations can be used, both IM as well as IV. So that's what we initially discussed, is the safest. So whatever you feel like, you can give IM also, you can give IV also, and all of you know we can give capsules also. So penicillin V, amoxicillin and amoxclav are only oral, like that is what I was telling, capsule. So V, not G, mind it, G is like injection. V, amox and amoxclav are only oral. Okay, rest are oral, IV as well as IM. And there is a new thing that you should remember. Do you remember that the penicillin G has got a very restricted function? So there is a thing called as procaine penicillin G and benzathine penicillin G. So they are used inside the muscle as depot form. Do you know depot drugs? Depot drugs mean certain drugs will be injected inside, say, your muscle. Now that muscle becomes a reservoir of that drug for the next couple of days. Slowly the drug will leach out, and accordingly over a period of time you are going to get the effect. So that is called as depot preparation. Could I explain? Are you understanding?
Yes, sir. Yes.
All right.
Yes, sir.
So you see, I have also given a picture which shows how ampicillin and sulbactam injections are available. So you will see that there is a shishi which contains powder, and then there is another thing, what do you say, cylinder kind of thing. It contains distilled water. So first you take a syringe, you take the distilled water, you push it inside the powder, you shake the bottle, you mix that powder with the distilled water, then you again drag it with your syringe. So over here let's talk about the absorption. So in absorption, what you need to know is that they must be administered 30 to 60 minutes before meal, or 2 to 3 hours postprandial. Okay, let's start from the beginning, whatever I have mentioned here. So they are incompletely absorbed after oral administration, and they reach intestine in sufficient amount to affect the composition of the intestinal flora. So that is why, intestinal flora, there is a bacteria, lactobacillus, Escherichia coli, they are very much essential for absorption. Do you know that?
No, sir.
Acha. So in our in our gut, we have symbiotic bacteria. They help in. So over there, if you are giving this kind of drugs, so they will be affecting this bacterial intestinal flora composition. Okay, that is why when we give drug, this amoxicillin, very commonly patient comes up and tell that after that there was loose motion. This is the reason. Okay. Now, specifically if we talk about amoxicillin, so amoxicillin is completely absorbed. but it is not appropriate therapy for Shigella or Salmonella enteritis because, like once again, therapeutic level do not reach the intestine. If you are taking food along with it, then penicillinase resistant penicillin absorption will decrease. You remember penicillinase resistant penicillins were also there, anti-staph and all. So their action will decrease because gastric emptying time will be lengthened and drugs will be destroyed in the acidic environment. So if you don't want the drugs to go ineffective, so you should take the drug 30 to 60 minutes before meal or 2 to 3 hours after meal. Okay. And as far as the distribution is concerned, they distribute well throughout the body. They cross the placental barrier, but like we discussed, it is safe. Okay, no teratogenic action will be seen. And bone or CSF is not good. Penetration into the bone and CSF is not good. So for any disease related to bones, say meningitis, where you have to pass through the skull and all, so in these cases don't use it. Okay, they are not very good. And in case of acute infection, the inflamed meninges are more permeable to penicillin. Okay, if the meninges are inflamed, so there is an increased ratio of the amount of drug in the central nervous system compared to the serum. You understand, na? Majority of the drug will get inside the CNS if the meninges are inflamed. Permeability increases. Understood?
Yes, sir.
Right. So if the inflammation dhire dhire subsides, then again the blood-brain barrier will be established. So penicillin levels in prostate are insufficient to be effective against the infection. So you cannot use in case of the prostate cases. And as far as the metabolism is concerned, so there is nothing specific about it. Excretion, so you remember that organic acid secretory system, there was organic acid secretion, OAT, in the total complete preliminary chapters. Pharmacokinetics we discussed, you remember?
Yes, sir. Mone ache.
Yeah. So that is the thing. So here also they are used. Okay, so patients with impaired renal function, you should have the adjusted dosage. You cannot give such kind of patients the regular dose because it is not going to get eliminated. And half-life of penicillin G can increase naturally in the presence of renal dysfunction. Now this is something which you should very well note it, that is probenecid. So probenecid inhibits penicillin's secretion. Okay, of course it is a competitive thing with the tubular secretion via organic acid transporter. So if imagine probenecid inhibits secretion of penicillin. So if probenecid inhibits secretion of penicillin, so penicillin is present in the blood for more longer time, less longer time, or same time. What do you think? Any idea?
ব্লাডে তো থাকছে তাহলে মানে
Correct.
লিপিডযুক্ত।
Very good. That means probenecid will prolong the action of penicillin. Similarly, if you if a lactating mother takes penicillin, so she should remember that it is passing on to the breast milk. Okay. Now nafcillin, dicloxacillin, and oxacillin are also not eliminated by the kidney. So this is a fact that you have to remember. Can't help. Understood, everyone? This part.
হ্যাঁ স্যার।
Okay. Moving on to the adverse reaction. So it is safest, but a common adverse reaction is cross allergy, hypersensitivity. I hope hypersensitivity everybody understands. I don't need to go into the details of that. Anaphylaxis, then lips can get swollen, tongue can get swollen. What do you call it? Angioedema. You remember these are all allergic response, isn't it? The point to note is that patients with mononucleosis, infectious mononucleosis is a disease, who are treated with ampicillin, incidence of rash, maculopapular rash, macule mane flattened, papule mane raised, so maculopapular rash, it increases. Okay, so that's why unless and until necessary, you should not use it. Unless and until you find that you are not allergic, you can use it. In case of allergy, don't use it. Okay. And there can be diarrhea. Reason I just told you why there will be diarrhea. And methicillin specifically is not used nowadays. Methicillin is banned. Why? Because methicillin was causing nephritis. Okay.
Okay, sir.
And sometimes if you are giving this drug intrathecal, in the intrathecal one, in your spinal cord. So over there, if intrathecally it is used, then it can also become overdose and can provoke seizure. Seizure, like epilepsy kind.
Yes, sir.
Yes. So there can be such kind of seizure also. Same goes if there is renal dysfunction. Seizure can take place. Okay. Then there can be some hematologic toxicities. Okay, because coagulation decreases if a person is using piperacillin, ticarcillin, nafcillin. Okay, and also penicillin G. So these are all bad penicillin. I don't recommend using these penicillins because it is again going to cause decreased coagulation. Okay, so why will a person use it? So if you are using for more than 2 weeks of therapy, there will be cytopenia. When do we have penia? If count increases or count decreases?
Increases.
Yes. So you see that will happen. Then there is another concept called as cation toxicity. Why? Because see, if you are giving penicillin, then it is available as sodium or potassium salt. So if you are taking penicillin large amount, then maybe penicillin is not the problem, but that excess sodium can cause the problem. Sodium excess can cause hypokalemia, na? Potassium less, kalium less, hypokalemia. Getting? If you are using aqueous penicillin G has got potassium salt. So if there is too much potassium, then you have to make sure that the heart is working fine. Ticarcillin also has got high sodium load. Understanding these things.
Yes, sir.
All right. Now our next topic is going to be cephalosporin. I think next class we start with cephalosporin then.
Yes, sir.
Okay. So fine. Let's stop over here today.